as we have been doing, we continue to go from assessment to treatment, simulating findings and essentially showing decisions that may be made. So as I have been doing, I have my standard approach to assessment. I have my standard macro motion. So macro identifies micro, large motions are made up of smaller subcomponents, and if there is a problem with the large motion, you'll identify the smaller subcomponents. So we're going to have you bend to your left and bend to your right, and we pretend that that's completely fine. So now I need to add in a test. So as I have done in the previous video, I add in a test. That looks fine, but the patient has complained of some pain in the back somewhere. So what we're going to have you do is twist to your left, and that looks fine, and then twist to your right. And then visually, obviously we're simulating, that looks very short. So the finding of the side bending is fine. However, the finding of rotation is a problem. So as you can see, I usually leave out rotation and flexion and extension. However, when the patient complains of back pain and I don't find anything on my primary scan, which is in the coronal plane, which is side bending, then I add in another plane. I tend to go to rotation first, and if I need to, I will go into the sagittal plane. However, in this case, I didn't need to, obviously simulated. So first finding, rotating left is fine, rotating right is poor. So if you were to call this an osteopathic diagnosis, it's rotating left. We'll have you on your back. So we continue on with the algorithm that I commonly use. Right, so we pretend as if the patient did not complain of anything else. And in straight leg raise, what we notice is the leg will go up, but it stays bent. Obviously, I'm simulating this, but this would be what the finding might look like. I can get the hip to 90 degrees, but the knee won't stay straight. So that makes me believe that there's something going on more likely than not with the hamstring, because the hamstring would limit knee extension. Right, so I have a finding of left rotation in the vertebral column. Very generally speaking, we could get more granular about it, but we don't have to. And I've noticed that there is essentially flexion of the left knee. Check through the arm. Arm looks relatively fine. The right arm. Check through the left arm. Staying consistent with my general process. Everything looks fine. Gross motion through the neck. Everything looks relatively fine. At least we pretend that it does. So now I need to make my choices. I need to deal with rotation in the vertebral column, and I need to at least further assess the left hamstring. So if I'm considering the fact that the patient is laying down right now, and I want the hamstring exposed, free to move in the plane or planes required, and preferably visible, my best choice for that is prone. That also allows me to expose the muscles of the vertebral column, so the erector mass, the lats, whichever muscles you'd like to speak of. It allows me to expose those, at which point I can assess them as well to see if they may be contributing to whatever's going on with the rotation. However, because it's a gross rotation issue, it's a little bit less likely that it's the erector mass. It's a little bit more likely that it's something such as the obliques. Okay, we'll have you flip to your front. And because I want to check through the left hamstring, I'm going to have to compare, but my soft tissue test of the left hamstring is essentially soft tissue healed. So I just press in as I would do with any other, well, not necessarily any other soft tissue. Depending on the soft tissues, I would often test perpendicular to fiber direction, but in the case of the quads and the hamstrings as a group, I would often just do lean on pressure and what I will do to make this more understandable, as I did last time with the quads, I tested on the same side, but I'll show you what I'd actually do. So I would test here, just trying to note. Now, as I get closer to the knee, it is expected that the tissue will often yield less because you're getting closer to tendons, but you can differentiate that because as you push in and you use broad contact for multi-point discrimination, you would expect that the tendons would be low on the hand, and that if there's something higher under the heel of the hand that does not necessarily present itself as ropey or somewhat linear, because that's what you would expect these tendons to feel like, you can suspect that that's a little bit more muscle. And you can get a little bit more pointed, so you go from a large sensor to a small sensor, right? So you can get a little bit more pointed. And I am identifying some portion of high tone tissue right about here. When I test the right leg, I come over to the other side. Same thing, lean in. And a similar amount of tension in the low hamstring on the right. So what I would want to do is deal with both of them. So I want to treat perpendicular to fiber direction. Now, although I noted a problem with the left knee, I've noted a lack of soft tissue yield on both hamstrings. So my aim is to deal with that. So perpendicular to fiber direction, I've got my short lever working in the area. So I want to go direct in this case because there's no particular pain for the patient. So if I push across, that's easy. I pull towards, that's harder, right? So I've got my short lever, my long lever, and what I do is I hold the tissue still and move the bone in relation to it. So that's relational motion. Can look like this. I can just do the short lever, pull towards, right? Then I would repeat the same thing on the other side, because as I said, although the leg moved fine and the knee did not stay bent, the leg stayed straight and went to 90 degrees, I did find high tone tissue here. So I would repeat the process in some way on this side. If there was tenderness, I would go indirect. If there was no tenderness, I would go direct. But as I showed you, just for visual purposes, short lever, push, pull, perpendicular to fiber direction, long lever, right? Hold the tissue still, move the bone in relation to it. That's relational motion. Because as I said, I want to check the soft tissue of the vertebral column. Just push it away from the spine. And essentially everything feels somewhat reasonable there. If I did find something, I would pause and work on it just as far as the soft tissue is concerned, because my large scan is a little bit more likely to tell me about the interplay between soft tissues and joints. When I actually push into soft tissue, that tells me more about soft tissue, so there's some differentiation there. I come around the other side to repeat the process. Again, this is just so that you see it. Okay. Now I need to retest the leg to see if everything went right. We'll have you on your back. So I want to retest it the way that I found it. And the way that I found it was with a straight leg raise. That's the test I need to redo. So you're going to ask yourself, well, why are you going to retest the leg before you're going to treat the vertebral column in rotation? Because I want to treat it in seated, because then it's all exposed, free to move, and the planar plane is required and preferably visible. It's not going to be as visible based on what I do. However, it is exposed and free to move and all the planes required. So I retest the leg. Lo and behold, we pretend that the problem that we found is fixed. So now, the reason I want to go into seated, so I'll have you sit on up and facing that way, to deal with the rotation, is because I have more options. I can immediately turn him, I can go indirect if I need to, and direct if I need to. I just have more options here. Give yourself a hug. Right, so he twisted well to the left, he didn't twist so well to the right. If I don't want to make a barrier choice, I can go indirect followed by direct. If I do want to make a barrier choice, and I pull him this way, and he says, ow, say ow, then I don't go that way, I go indirect, right? So we just go to soft tissue ease. So I'm using good contact, my torso is approximating the patient's back. I can use my hand very broadly and spread it out like this, and I can go into the soft tissues until I feel some form of softening, right? I wait, I go more into ease, more into soft tissue softening. Then what I would do is come back, and if he doesn't say ow and he doesn't say ow, now I can approach this. Now, even though I'm going into the direct barrier, I can still do it in a way that I start to attempt to find some softening, or maybe a lack of resistance into the motion restriction. I can do it that way. Now, it's not absolutely the case, but I can do that. Then I can go in. Right now, if I wanted to use relational motion in this sense, or I wanted to use a patient active approach, the way that most people are commonly taught this is they would be taught to activate in the opposing direction that they're moving. So I would tell you to turn backwards to your left, right, and relax. Now my problem with that is that that's activating the muscles that might be upset, that might create some negative sensation for the patient, and also I get into a bit of a wrestling match. Now what I do, and I've shown this before, just push your left leg straight down onto the table and let it relax. And you see his whole body wiggle. Push your right leg down on the table and let it relax. And whichever one of those gave me more of what I wanted, right? So I hold the body still and I wiggle the legs underneath it, so the pelvis wiggles, which means the lumbar column moves to some degree. Push your left leg down and let it relax. And your left leg down again and let it relax. And your left leg again and let it relax. I take them further in. Now I need to rerun the test that I found it with. So we twist your left, good, and then because it worked, twist your right and it'll go farther, right? So I need to rerun the test that I found it with. So hopefully, with all the rambling, you're able to pick up on why I made the choices in the sequence that I made them. I even threw in the idea of not making a barrier choice or going indirect followed by direct, or having a pain cue, so I go indirect first because I have the pain cue. So all of those ideas are embedded within that, and hopefully that helps you have some more examples of what this all looks like when put together.